Good afternoon. My name is Thomas Wilkinson. I'm a research fellow from the University of Leicester in the UK. I'm really delighted to be part of the GREC Symposium here at Transplantoux. And today I'm going to be talking about the first UK exercise and lifestyle in CKD clinical practice guidelines that we've been developing over the last few years. I'm going to start by giving a bit of an introduction to why this was important and why this was needed, talk about the guideline development process. I'm going to give a few headlines for the non-dialysis CKD group and the haemodialysis groups. I'm going to go into the kidney transplant recipient recommendations in a little bit more detail, given the nature of Transplantoux, touch upon alcohol, smoking and drug use, and then finish with some take-home messages. I'm going to say at the start that we didn't include any diet or nutrition recommendations in this guideline document. It was deemed that the nutrition and the diet elements have their own quite comprehensive guidelines, and particularly in the UK, these are being revised currently. And we also haven't included recommendations for peritoneal dialysis. But some of you all know that guidelines around exercise and physical activity and lifestyle have recently been published by the GREC's group. I'm going to start off by the acknowledgements rather than keeping these to the end. Hopefully this is just to highlight the sheer amount of people that are involved in developing these guidelines and recommendations from a vast amount of institutes from around the UK. I've highlighted a couple of people. Luke Baker from the University of Leicester led the non-dialysis section, and Daniel March from the University of Leicester, who's now at York. He led the haemodialysis group. And Professor James Burton from Leicester, he was the chair of the guideline working committee and really helped bring things together and keep everybody on track. So a special thank you to those three people. So for some of you who may not be aware, we know that the prevalence of physical inactivity in CKD is extremely high. And this is a graph taken from a study that we published last year. And you can see that the black bar indicates physical inactivity. So these are people who aren't reaching the recommended government guidelines around physical activity. And in the UK, that's 150 minutes per week. And what you can see is that as we progress from left to right, the black bar goes up. So as we progress from mild stages of CKD through to those on kidney replacement therapies, so the haemodialysis and the peritoneal dialysis groups, physical inactivity is extremely high. You'll see that in the transplant group at the very end, that having a transplant seems to have a beneficial on activity levels, but it doesn't quite return to those of the earlier stages, and there's still a significant amount of people who are inactive. And overall, the evidence now suggests that increasing physical activity levels, whether that be through exercise or just general activity, has great benefits on health outcomes. But there's quite a limited consensus on what type of physical activity in particular is important in those with kidney disease. And in CKD clinical guidelines, but also international guidelines, there's really only quite minor references to the importance of lifestyle. And they really give very little away in terms of what a healthcare professional should be advising their patient to do. So because of these reasons, in 2019, the UK Kidney Association commissioned the publication of the first ever UK clinical practice guidelines on exercise and lifestyle in CKD. These would be NICE endorsed. As I said, the focus was more around physical activity and exercise, but we did include a weight management section and how physical activity can be used as an important tool when dealing with a patient's weight. Particularly, this is clearly important in transplant patients. We also made sure we included implementation tips to help readers and to help healthcare professionals apply the guidelines and apply the recommendations to their own clinical practice. So this is a schematic overview of the development process. So starting in the top left-hand corner in the red box, themes were decided a priori by the UK Kidney Research Clinical Study Group. So these were things like physical activity, exercise, weight management, the decision not to include nutrition. Working groups then were assigned for each theme and particularly each area of disease, and each group systematically reviewed the evidence and the research around that to inform recommendations and guidelines. Each working group then graded the recommendations, and these recommendations were graded based on the following. Firstly, the level of recommendations, whether this was a strong recommendation or a weak recommendation, and also the quality of evidence. Was this recommendation based on high quality evidence from RCTs, or was it based on very low quality evidence, potentially from cross-sectional studies of small sample size or opinion and case reports? Once we had a draft, this was sent out to an external peer review, and this was UK-wide, in fact international-wide, anybody could comment on it. And then we revised and confirmed the recommendations and guidelines, and these were done by the core group. So in terms of the non-dialysis CKD group, these were really kind of a summary of the main headlines. We didn't find any reason to suggest that the non-dialysis patients should not be aiming for 150 minutes of moderate physical activity. This could involve 75 minutes of vigorous physical activity. Recommend that breaking up long periods of sedentary is important. This could be with light activity or standing. And we had enough evidence to suggest that increasing physical activity can improve blood pressure, physical function and physical capacity, and also improve health-related quality of life. You'll see that these are all strong recommendations, although the level of the quality of evidence, I should say, wasn't the highest tier. So these aren't potentially coming from well-conducted RCTs. Recommend that a combination of aerobic and strength training should be used, and that exercise has the ability or the potential to improve well-being. So this could be through reducing symptom burden or depression and anxiety. In the hemodialysis group, again, very similar. We found no evidence to suggest that hemodialysis patients shouldn't be encouraged to exercise or can be physically active, especially when there's no contraindications. Like the non-dialysis group, they should aim for 150 minutes of moderate intensity a week. And this can involve a combination of exercise, potentially outside dialysis, or exercise during dialysis. We suggest that physical activity may reduce the risk of cardiovascular related and also all-cause mortality. And there is some evidence to suggest that physical activity and exercise may have favourable effects on blood pressure. In terms of the kidney transplant recipient group, again, the headlines were very similar. There's no evidence to suggest that people with a kidney transplant shouldn't be aiming to do 150 moderate or 75 minutes vigorous physical activity per week. We found enough evidence from RCTs that structured exercise can increase exercise capacity, can increase strength and physical function, improve quality of life, and HDL levels. We found that exercise alone is unlikely to attenuate the increases in body mass that are often seen after a transplant. And this is potentially where nutritional diet aspects will certainly come into it. Aerobic exercise should be performed at least above 60% maximum heart rate or VO2 peak. And resistance training, both upper and lower body, should be performed at above 60%, 1 repetition max. And we would suggest this occurs at least twice a week. And again, patients should be encouraged to minimize sedentary time. I'm going to focus on a couple of highlights, a couple of different elements that we found when we came to do the transplant guidelines. Clearly a big element in transplant rehabilitation is recommendations post-transplant. So we were quite interested in what people should be doing kind of immediately after they've had the transplant. And this was the recommendation that we came to. We found that immediate physical activity or exercise intervention immediately conducted after transplant, so this was within a couple of days, was not beneficial in increasing the recovery or attenuating any declines in physical function that may have occurred from having a transplant. And this comes from quite a small amount of evidence from a couple of trials, but it suggests that actually exercise doesn't provide any additional benefits immediately after transplant, particularly within the first few days. This isn't to say that we shouldn't be doing anything. Certainly, those two studies showed that simple mobility exercises were useful, but intensive physiotherapy and structured exercise didn't stop the decline in physical capacity immediately post-transplant. But clearly a lot more work has to be done about optimizing that recovery post-transplant, and particularly in the first few days or so. Another area of interest is clearly the pre-transplant time. And this was the recommendation that we had for pre-transplant. So we've said that prehabilitation may help increase pre-transplant physical activity levels and aid recovery post-transplant. We gave this a grading of 2C, so it's the evidence isn't quite strong enough yet, and this recommendation comes from quite limited evidence currently on the role of prehabilitation in kidney transplant recipients, and this is primarily taken from a study in the US that suggested that prehabilitation, so this was just one session a week, is feasible, but particularly up to 12 sessions is also feasible. They found that physical activity was increased by 64% in those patients undergoing that prehabilitation program. And what was quite interesting was post-transplant, the length of stay was halved in those engaging with the prehabilitation program. And certainly there was evidence to suggest that the more sessions patients did, the better those outcomes were. But again, clearly more evidence is really needed into the role of prehabilitation in transplant recipients. This was just a figure just to highlight the increases in physical activity. And what you can see here is if you had more prehabilitation, so that's the green line, the greater the increases in physical activity were throughout the day. Whereas actually, if you only did kind of a month of prehabilitation, the outcomes weren't quite the same. So clearly there's also a dose response element to this. We touched on alcohol, smoking and drug use as well, and we were able to kind of make quite a sweeping recommendation across the all stages. And essentially this was that smoking should be stopped. There wasn't really any evidence to suggest that alcohol consumption shouldn't be within the national guidelines, and to avoid all recreational drug use. And these recommendations were really made in light of quite overwhelming evidence in both the general population but also the kidney disease literature. So I'm going to finish just by talking about some take-home messages. So we found that for all kidney disease populations, it's recommended that they meet the UK Chief Medical Officer guideline for physical activity. But we want to conclude and we want to state that really any physical activity is going to be beneficial, and certainly any is better than none. The benefits of meeting physical activity recommendations are really now quite compelling, and the message is really quite clear now that being active really does provide a foundation for a much better and healthier life. If possible, outside just general physical activity, we found that structured programs of physical activity, particularly exercise, are most beneficial if they're supervised by an appropriately trained individual. So this could be a physiotherapist, sports scientist, or rehabilitation specialist. And if you want to find out more information about the guidelines or read the entire document, it's readily available online at this link. If you scan the QR code with your phone, it should take you straight to the page. The guideline will be published in the next few months in BMC nephrology, so keep an eye out for those as well. As I said at the start, the document has implementation tips about implementing and taking those recommendations and using them in clinical practice. So I'd just like to thank you all for listening. And if anybody has any more questions, please email me or find me on social media, and I'll be happy to answer any questions in the Q&A that follow. Thank you very much.